How can we improve the outcome of VR surgery? Non-modifiable factors for the surgeon is the surgery itself, but the modifiable factors is the view. Best of the best surgeons with favorable patient factors suffers in the hands of poor visualization. In this video, we highlight the importance of a magnified view with higher resolution. The magnification with the supermacular lens is twice than that of a plano or a concave direct image lens, hence making it an ideal lens for dissection in fractional membranes, internal limiting membrane peeling in macular holes, ERM removals and other complex macular and submacular surgeries. The first scenario, a 3-port pars plana vitrectomy has been done. Core vitrectomy with truncation of the central cone and a posterior vitreous detachment has been completed. The posterior hyaloid staining with intravitreal triamcinolone done. Initiation of membrane dissection under high magnification with the help of a 23 gauge vitrectomy cutter and an intravitreal forceps used. We noticed that the magnifying view with the clearer details of the membrane and the plane of dissection reduces the iatrogenic breaks. It is most important for the beginners with less experience to understand the plane and for good stereopsis. The bleeders have been cauterized with a diathermy. After media clarity achieved, a 360 degrees endolaser was completed, a fluid air exchange was then done, and the fluid pockets around the brakes have been drained with the help of a soft tip and the silicone oil was injected. The second scenario, a 3-port pars plana vitrectomy has been done, followed by a core vitrectomy and completion of a PVD. A further membrane dissection from the posterior pole with the help of an intravitreal forceps and completed using a 23 gauge vitrectomy cutter. A hard and a soft tip was used to clear the blood from the field and enhance further visualization. The membrane dissection was completed, all the bleeders were cauterized, and a 360 degrees endolaser was completed. A fluid air exchange was done and a 1300 centistokes of silicone oil injection was done. In the third case scenario, once again a pars plana vitrectomy was started. With completion of a core vitrectomy, the posterior hyaloid was stained with intravitreal triamcinolone acetonide. The next step was membrane dissection using a vitrector. A high magnification view assisted by the intravitreal forceps. The bleeders were further cauterized. The membrane dissection was completed. A hard and a soft tip was used. A fluid air exchange was done, followed by a 360 degrees endo laser. And a silicone oil injection was done with stable retina. We would like to conclude that utilization of high magnification lens in the removal of membranes in complex diabetic fractional retinal detachment is a boon and also a blessing, and is uncontested for careful and delicate removal of fractional membranes, thus decreasing the occurrence of iatrogenic retinal breaks, making the visual outcome better and also the anatomical outcome.